Our third reactor is Commander Jamie Fitch. She is the Commander Medical Corps, U.S. Navy, Deputy Trauma Director of the Trauma Burn and Rehabilitative Medicine Team, Office of Defense Partnership, United States, and Embassy Abu Dhabi, United Arab Emirates. Let us all welcome Commander Jamie Fitch for her reaction.
Hi, good afternoon, good morning, good evening, everybody. And thank you so much for the opportunity to participate in this webinar. I thoroughly enjoyed all four of the talks. As mentioned there, I've had a rather unique opportunity in this last year to be working in a relatively recently opened hospital here in Abu Dhabi in the United Arab Emirates as part of a team that's developing the trauma program for that hospital. And so it's been very interesting to sort of start from the ground and build the trauma program to what we think it should be for high quality trauma care. The topics today were very pertinent to that. Dr. Beauford spoke about the importance of planned resuscitation and directed resuscitation in our massive transfusion patients. One of the things we had to develop here in Abu Dhabi was the massive transfusion protocol for our hospital. And it's surprising how many people it takes to put together the team to appropriately build all of the pieces that you need for a real effective massive transfusion protocol. You know, the focus was decreasing the amount of normal saline that we give to these patients, getting to a point where we get a 1-to-1-to-1 ratio right from the very beginning. And that took a team of 15 to 20 people across every department, from the blood bank to the lab to nursing staff to the emergency department physicians and the surgeons. Because as we all know, it doesn't matter how effective I can be in the operating room if the patient can't get the right ratio of blood and we get into that cycle of coagulopathic bleeding. I can't do much about that surgically without that right ratio. And so the challenge became getting all of the pieces in the hospital together to make sure that we could get the blood rapidly to the bedside, and all of those adjunctive therapies that you talked about, fibrinogen, TXA, in the right patient. Trying to stop the practice of giving TXA to every patient that's bleeding a little bit, but getting it rapidly to those that need it. Fibrinogen rapidly available at the bedside, and the ratio of blood products. We've added liquid plasma is becoming available so that we can get it more quickly. And that's very useful, and it's critical to what we do. So I think that the point to emphasize is not just the physicians knowing how much blood they need to give or what the ratio is, but the process to actually get that blood to the bedside thawed quickly and into the arm of the patient while we're moving them to the places of hemorrhage control. Which moves us on to Dr. Scott's talk about the Raptor suite. I would challenge that the hybrid suite is maybe not the perfect place for every patient, but it is certainly the place to be if you need to have the flexibility to do endovascular repairs at the same time being able to rapidly get into the abdomen. What we've discovered here is that developing a program for the hybrid suite, as Dr. Scott pointed out, is also more than just buying the fancy equipment. When you have the hybrid suite available, it's not really useful if there's not a pre-established plan for how to use it. And so one of the things that we encountered was when IR was going to take care of a bleeding patient, the surgeons want to disappear. Okay, they've got it. It's their problem now. I can go back to bed. And simultaneously, if the surgeons are going to operate, then IR isn't coming in. The interventional radiologists have all of their equipment, all of their different wires and balloons and things already organized in their angiography suite downstairs, and don't necessarily have all of the same equipment available in the hybrid suite. And so figuring out a plan so that you know exactly what is needed in those places, exactly what they need to have rapidly available, and that their technologists know how to find it in the operating room as easily as they do in the angio suite is critical to making them effective there. So I think the overall theme I heard from all four speakers was the team that's needed for trauma care, and that's one of the statements I make almost on a weekly basis. Is trauma is a team sport, and the trauma surgeons can't run it alone. The ED doctors can't run it alone. We all have to work together to figure out what the best plan is, and that plan has to be in place before the bleeding patient comes in order for all of those systems and the fancy equipment that we've bought to be effective in stopping the bleeding. Dr. Razek talked about the importance of that ratio of blood transfusion and the possibility of switching over to whole blood. I strongly advocate using whole blood when we can give it. As he pointed out, it's important to give the patient what they're losing. They're not losing packed red cells. They're not losing fresh frozen plasma. They're losing blood. And so if you have the ability to give fresh whole blood, especially at the very beginning of a resuscitation, before you have lab results available, even thromboelastography, while it's great information, takes a little bit of time to get results. And so if you have the ability and that infrastructure to be able to give fresh whole blood at the beginning until you can get that lab data to help better guide some of the other resuscitation products, that can very effectively speed up the correction of coagulopathy and even prevent the development of that coagulopathy from the beginning. And then finally, in Dr. Sengthong's talk, that was a great review of the data that we have for hemothoraces and which ones do we need to drain and which ones do we not. As you point out, you know, that data is somewhat lacking in that there are some mixed results. In some patients you can watch it, in some patients you can't. And what does that do to the length of time in the hospital, to their overall risk of developing a fibrothorax? And as you point out, you know, we definitely need more data upon which to base these kind of decisions. I would be curious into your thoughts as to how we obtain that data. How would you design those kind of studies? And how would you safely compare those observation versus tube versus even a VATS clean out? How would you set that up on the beginning, and how would you divide the patients up to decide how to safely get that data? Because I agree, we absolutely need better data upon which to base those decisions for our patients. Thank you again for the opportunity to comment. I thoroughly enjoyed this session.